Good morning, good afternoon, or good evening. Welcome to the presentation of student project from Group B8 titled Update on Pathogenesis and Conservative Management of Acute Kidney Injury Patient. My name is Ajeni Saidina Pakpahan with student number 031 and I would like to start the presentation. These are the members of our group. Okay, I would like to start from chapter 1, Introduction. For the background information, acute kidney injury or AKI is described as a quick loss of kidney function lasting hours to days, as seen by high blood creatinine levels and oliguria, which causes an inability to maintain water balance, acid base, and electrolytes. This decrease in renal function could be due to various factors, including complex pathophysiological mechanisms. AKI is a prevalent condition, particularly in hospitalized patients. The incidence ranges from 5% to 7.5% in hospitalized patients and 50 to 60% in severely ill individuals. AKI can have serious consequences, including an increased risk of cardiovascular events, CKD development, and long-term mortality. The aging population, the growth in predisposing comorbidities, and the growing use of nephrotoxic drugs and invasive procedures are only a few of the reasons that may be contributing to the rising prevalence of AKI over time. AKI's pathogenesis is etiology-driven and classified into prerenal, intrinsic renal, and postrenal. Each of these categories has a variety of linked causes, and several causal variables for AKI have overlapping injury mechanisms. The prognosis of AKI patients varies because it is not a single disease, but rather a complex and heterogeneous syndrome consisting of several distinct entities, ranging from relatively benign conditions like pre- and postrenal AKI to multi-organ failure. AKI episode stage and durations, patient's age, underlying CKD, baseline renal function, organ failure, sepsis, chronic comorbidities, and the event of renal recovery all contribute to the probability of unfavorable outcomes in addition to the etiology. However, the current treatment available for AKI is primarily conservative. No therapeutic modalities to date have shown efficacy in treating the condition. Thus, the goal of the treatment is to prevent further damage and promote recovery of renal function. Due to the importance of these matters, medical students must study the pathogenesis and conservative management of acute kidney injury further. Within this narrative review, we aim to help medical students learn more about the pathogenesis and conservative management of acute kidney injury by dividing it into a problem formulation. And I think that is all from me. Thank you.
Thank you for the opportunity. My name is Rasa Felani with the last three digits of student number being 168. And now I'll be presenting about the problem formulation, objective, and benefit of the student project. So for the problem formulation, what is the definition of acute kidney injury or AKI? What is the etiology and risk factor of AKI? What is the pathogenesis of AKI? What are the clinical manifestation of AKI? What are the diagnosis of AKI? And what are the conservative management strategies for AKI? For the objectives are to know the definition of AKI, to know the etiology and risk factor of AKI, to know the pathogenesis of AKI, to know the clinical manifestation of AKI, to know the diagnosis of AKI, and to know the conservative management strategies for AKI. For the benefit, the first one are the theoretical benefit is to obtain information and provide new understanding about the pathogenesis and conservative management strategies of AKI and to obtain references for future research. For the practical benefits is to enhance medical skills, including management and education to patients through the theory acquired in the study. That's all from me. The presentation will be continued by my friend.
Hello, my name is Gusti Agung Ayu Adinda Vidila Trisna Putri with my last three digit of student numbers are 232. So today I'm going to explaining about the chapter 2 content of our student project. So today I'm going to explaining about the definition of acute kidney injury. So acute kidney injury is defined as a sudden loss of kidney function characterized by a significant decrease in glomerular filtration rate or GFR, manifested by increased serum creatinine levels and decrease in urinary output or oliguria. It is characterized by an increase in serum creatinine by 0.3 mg per deciliter or more within 48 hours, 1.5 times or more than the baseline value, and or having a urine volume of less than 0.5 milliliter per kilogram per hours for at least 6 hours. Acute kidney injury affects approximately 10 to 15% of hospitalized patients, while its incidence in intensive care has been reported to affect nearly 50% of patients. And acute kidney injury is associated with increased risk of cardiovascular events, development to chronic kidney disease, and even mortality. Well, I think that's all for me. Thank you.
Thank you for the opportunity given. Let me introduce myself. My name is Angela Felicis Morangkir with the last digit of my student ID is 098. I'd like to explain about the etiology and risk factor of acute kidney injury. So acute kidney injury can arise from various underlying causes and risk factors. Dehydration and hypotension can impair renal perfusion, while infections and exposure to natriuretic substances like certain medications or contrast agents can directly damage kidney function. Additionally, individuals with pre-existing conditions such as chronic kidney disease, diabetes, or hypertension are more susceptible to AKI due to compromised renal health. Advanced age, surgical procedures, and critical illness further elevate the risk too. And risk factors for AKI or acute kidney injury include environmental, socioeconomic, and cultural factors. About the environmental factors include inadequate drinking and wastewater systems, insufficient control of infectious disease, and insufficient healthcare systems. Further important risk factors for acute kidney injury are severe disease, acute infection, sepsis, severe trauma, major surgeries including cardiac surgery, and being in the ICU with exposure to opportunistic infections, as well as chemotherapy for leukemia or cancer, autoimmune disorders, cholesterol crystal embolism, and urinary tract obstruction. That's all from me. The next slide will be presented by my colleague. Thank you.
Hello, my name is Joshua, my last read number 205. Next, I'm going to talk about pathogenesis. Acute kidney injuries pathogenesis is driven by the etiology. A cellular insult brought by ischemia or direct toxin is the typical endpoint of acute tubular necrosis. This causes the brush boundary to be erased, tubular cells to die, and their ability to function is reduced. Intrarenal causes include intrabular blockage, which can potentially result in the same outcome. Examples of such obstruction include pyxins like myoglobin, crystal like uric acid in tumor lysis syndrome, and immunoglobulin light chains as in monoclonal gammopathy. Acute interstitial nephritis or glomerulonephritis are other intrarenal mechanisms of injury that can result from inflammatory reaction, immune complex deposition, or immunological mediated destruction of the vascular rate, which can damage the tubulus and glomeruli. Reduced renal perfusion, tubular atrophy, and interstitial inflammation are among the symptoms of post-renal pathology, which is typically associated with urine reflux. And for the next part will be assessed by my friend Brian. Thank you.
Hello, my name is Brian Chandra with the last digit 152, and I'm going to continue with the pathogenesis of acute kidney injury. So there are two more pathogenesis of acute kidney injury. The first one is sepsis induced. It is the condition of kidney inflammation in which the condition progresses due to the rises of blood transportation, which causes the damage of GFR. The second one is toxic induced kidney injury. This condition arises where the toxins that are consumed are responsible for acute kidney injury. This first used keyword injury means local alteration, especially in the nephron tubule. The kidney, functioning as a filtration system, secretes waste products, has a greater propensity to be affected by environmental toxicants. That's all from me. Thank you.
My name is Zepina Dela with the last digit of ID number is 094. Clinical manifestation of acute kidney injury or AKI. Cause-effect relationship in acute kidney injury is difficult to distinguish. It can show different clinical manifestation in each individual depending on the cause, severity, and comorbidity. AKI can be seen by urine output and its cause, such as oliguria, sudden anuria, and polyuria. This is due to renal compensation due to decreased perfusion by concentrating urine and reabsorbing sodium to normalize renal perfusion and continuously increase intravascular volume. AKI has caused fluid overload or hypervolemia and vice versa due to capillary leakage. This also can cause swelling in legs, ankle, or fluid. Another clinical manifestation include proteinuria and hematuria that progress to chronic kidney disease. That's all for me. Thank you.
Hello, my name is Indirana Nataseno with last digit name 091. The diagnosis: acute kidney injury or AKI can be diagnosed through serum creatinine level or glomerular filtration rate, increasing number of SCR by over 1.5 times of the baseline value in 7 days prior, or decrease in GFR by 25%. There are several biomarkers of AKI. There are stress marker, damage marker, functional marker, and these biomarkers are based on the Acute Disease Quality Initiative Consensus Conference. The next part will be explained by my colleague.
My name is Idewa Ibaraswarimisi, which the last digit of master number is 074. I will continue to explain about the diagnosis. Cell stress is reflected by stress indicators and can either subside or intensify. Damage marker denotes structural impairment that might or might not cause renal function to decline. Changes in glomerular filtration correspond with functional indicators. These biomarkers can provide a more accurate approach than assessing UO or SCR level alone, and they may also point to the most effective treatment and diagnostic strategies. So these are the stress marker, damage marker, and functional marker of urine and plasma.
Hello, my name is Nikita Devi Di Prastiti with last three-digit number 028, and I would like to explain about the management of acute kidney injury. The first part is fluid management. Intravascular hypovolemia is the only condition where fluid delivery is indicated in acute kidney injury. The purpose of fluid administration is to manage intravascular hypovolemia without increasing fluid excess and its related side effects that include the onset or progression of acute kidney injury. When treating critically ill patients with acute kidney injury, saline is still the most often utilized crystalloid. When circulatory failure symptoms have subsided, there are suggested early signs of fluid overload or dynamic test finding shows that the patient is no longer receptive to fluids. Fluid administration should be discontinued. In order to maximize the volume status, physicians need to adapt their care to each patient needs when it comes to administering fluid treatment. The second management is acid-base and electrolyte management, where acute kidney injury commonly arises with acid-base and electrolyte disturbances, such as metabolic acidosis, hyperkalemia, and hypocalcemia. In the case of severe metabolic acidosis, which is typically described as pH value of less than 7, bicarbonate buffer solutions are the most commonly administered solution for life-threatening metabolic acidosis. Another common side effect of acute kidney injury is hyperkalemia. When treating severe or potentially life-threatening hyperkalemia, emergency intermittent hemodialysis is preferred over continuous renal replacement therapy because it offers a greater clearance rate in a few hours. In a lot of cases, acute kidney injury also frequently causes hypocalcemia. Patients who are asymptomatic and experience acute hypocalcemia symptoms are advised to receive IV calcium. If hypocalcemia does not improve, then a continuous infusion should be started. To stop the precipitation of calcium salts, alkaline solutions such as bicarbonate and phosphorus containing solution should be avoided through the same IV. That's all from me. It will be continued by my friends. Thank you.
My name is Putu Krishna Arsawadini Putri with last digit number 027, and I will present about the pharmacological treatment of acute kidney injury. Treating the underlying cause in acute kidney injury is crucial for achieving optimal outcomes, as pharmacological treatments that do not address the causative factor may provide limited efficacy in reversing kidney injury. One of the pharmacological treatment is norepinephrine, which is the first-line vasopressor for maintaining adequate perfusion pressure in patients with acute kidney injury. Other vasopressors, such as vasopressin and phenylephrine, are alternatives for patients who do not respond to norepinephrine. Loop diuretics, such as furosemide, may be used in acute kidney injury to manage fluid overload, but their routine use for prevention or treatment of AKI is not recommended. Managing complications such as hyperkalemia, hyponatremia, and metabolic acidosis is crucial. Treatments may include the use of potassium binders, calcium gluconate, beta-2 adrenergic agonist, and insulin with glucose to shift potassium into cells. Intravenous sodium bicarbonate is used in cases with metabolic acidosis. And acetylcysteine has been investigated as a nephroprotective agent in AKI due to its antioxidant and vasodilatory properties. However, evidence supporting its routine use is limited. Emerging therapies for AKI, such as stem cell and regenerative medicine techniques, show promise for future treatment options, and investigations into renoprotective agents such as adenosine antagonist, erythropoietin, and natriuretic peptides are ongoing. And for the nutritional management, protein intake is often moderated in acute kidney injury to minimize the production of nitrogenous waste. KDIGO guidelines recommend limiting protein intake to approximately zero point 0.8 to 1 gram per kilogram per day based on the severity of the injury and patient's needs. Adequate energy intake from carbohydrates and fats can help prevent muscle wasting and support overall nutritional needs. Maintaining balance in potassium, sodium, calcium, magnesium, and phosphorus is essential to support recovery and avoid complications. Proper hydration is also crucial but must be closely monitored to avoid fluid overload.
Okay, thank you for the time. My name is Nyoman Galisa Trasjana with last digit subname number 011, and I'm going to conclude our student project. Next slide, please. Okay, thank you. So acute kidney injury is defined as a sudden loss of kidney functions characterized by a significant decrease in glomerular filtration rate. It's related by various etiologies and risk factors, such infections, nephrotoxic substances, and pre-existing individual, for example, age, surgical procedures, and medical conditions. Mainly, acute kidney injury arises when there is an ischemic condition that was induced by underlying factors, which is leading to cellular damage. Patients usually experience oliguria, cystinuria, swelling, shortness of breath, proteinuria, and hematuria. Acute kidney injury is characterized by the presence of an elevation of serum creatinine level 1.5 times over the value, or 25% decreasement of glomerular filtration rate, or specific biomarkers for acute kidney injury, for example, stress, damage, and functional. The principle of latest conservative management are focused on managing intravascular hypovolemia and electrolyte acid-base balance, maintaining adequate perfusion pressure, preventing complications, and moderate protein intake. I think that's all from me. Thank you. Okay, so that was the end of our student project presentations, SGDBA. I think that's all from us. Thank you.